Given that it is 3:01, let's go ahead and open up the January regular meeting for the Local Alcohol and Drug Planning Committee. My name is Eric Dyer. I chair this meeting. I'm also the director of Jackson County Community Justice. Present today for his first official meeting as our liaison is Commissioner Rick Dyer. Commissioner Dyer, do you want to say hi and introduce yourself to the group?
Yeah. Hello, everyone. It's actually not my first official LADPC. It's my first in 2 years, but I did it for 4 years prior to that. You forget these things, Eric.
That is very true, Commissioner. I apologize.
You're hurting my feelings. No, it's great to be back. I appreciate the work that this committee does. So,
it's
like I said, great to be back with you.
Thank you very much. So, all right. Looking to the agenda, we have a roll call of members and roundtable introductions of guest and staff. So let's go ahead and do this in terms of, I'll go ahead and say your name. And if you just want to talk about who you are, whether you're a member and the agency you're with, and if I misrepresent the fact that you've dedicated 4 years to this group, please let me know about it, because that is a good commitment. So Nick, why don't you go ahead and start off?
I'm Nick Wrighton, parole and probation.
And a member, all right.
And a member, excuse me, a member, yes.
All right. John B.
Good afternoon, John Bain, Phoenix Counseling Center.
Thanks, John. Nathan.
Hi, I'm Nathan Olsen. I'm the outpatient clinical director at Addictions Recovery Center.
And Kim.
I'm Kim. I'm the chief clinical officer at Addictions Recovery Center, and I just got an urgent matter to manage, so I'm going to leave you in Nathan's capable hands. I apologize.
All right. Well, good to see you. Hope that it goes well. Thank you. All right. Justin. That might have just knocked out. Mike O'Malley.
Hi, Mike O'Malley. I'm a member, formal volunteer in quality at the VA and a CARF surveyor.
And due to your Zoom picture, an excellent drummer at that. So all of these things. Right. Brandon.
Brandon Orr, Reclaiming Lives Recovery Cafe.
Great. Stormy.
Stormy Bauman, La Clinica.
Jennifer.
Jennifer Barchesh, Staff Recording Secretary.
Great. Rosemary.
Good afternoon, Rosemary Jernigan, Oregon Department of Human Services, and a member.
Thank you. Eddie.
Eddie Wallace, On Track.
Mr. Swanson.
Hey, everybody. Andrew Swanson, Oregon Recovers.
All right. Dane.
Dane Zahner, HIV Alliance, he, him, and his pronouns, and Southern Oregon's Prevention Manager in Harm Reduction.
Awesome. Welcome. Darren.
Hi, everybody. It's Darren Dale, JCC Behavioral Health Manager. And just, I'll be joined later by our director, Julia Jackson, who's our director of behavioral health, who will join us at the halfway mark.
Great.
Non-member.
Non-member. All right. Joanna.
Hi, my name is Joanna. I'm from Medford Treatment Center. I'm the clinical supervisor, and I am not a member.
All right. Bill Matz.
Yep, it's communications for the county, Reclaiming Lives Recovery Cafe, and help Eric out when he asked me to.
Much appreciated. Thank you. All right, Heather.
Heather Phillip, I am a member, and I am a supervisor for HUD Bash at the VA in White City.
Great. Amanda.
Hi, everyone. Amanda Eisenhower. I'm a member, and I work as a social worker program coordinator for geriatric and extended care at the VA.
We have a call in from 941-5860 if you wanted to say hi.
Hi, Eric. This is Jody from Allied Health.
Great, Jody. Glad to have you here.
Thank
Julia.
you.
Yeah.
Hi there, Julia Pinsky from Access Mission and Chester in the back.
With Chester, you're great. He's excited to be here. All right.
Very happy to be here.
Great. John.
Hey, I'm John Watson. I'm the Assistant Director of Community Justice. I'm also the chair of the Mental Health and Developmental Disabilities Advisory Council, and I'm a guest.
Great. Justin.
Hey everyone, Justin Schumacher, Boulder Care. I'm doing MAT online. Happy to be here, non-member.
All right. Justin Hahn. As I catch you mid-drink.
Sorry, I just arrived late. What are we doing, Eric?
Oh, just your name, whether you're a member, and who you're affiliated with loosely.
Justin Hahn. I am a member, and I am the current member or the manager of the temporary urban camp.
Awesome. All right. Thank you. Kristen.
Hi, I'm Kristen Johnson. I am not a member, and I am with the Oasis Center of the Rogue Valley. Nice to see you all.
Thanks for being here. Dana Peterson from OHA, you said you were having some sound issues. If you can join us and say hi, great. If not, I will just say you are a longstanding member of this, or not member, but a participant in this group with your work through OHA and your work for substance use disorder for the state of Oregon. Hopefully that covers some of it. I know you've got some other titles I'm missing, and if your audio gets worked out, we'd love for an update later. Jeffrey.
Hey everyone, good afternoon. Jeffrey Piacitelli, Behavioral Health Care Coordination Supervisor with All Care Health.
Great, welcome. And Ms. McCready. Well, maybe not. Maybe we'll hear a little bit later, so I'm okay with that too. Let's see, Jennifer, do we have a quorum at this point in this meeting?
I don't believe so. I think we're at 6.
Okay. Well, we had some minutes to approve, but we can hold them over for next month. This meeting will be advisory in nature, but we can move on to our updates. And I'm not sure that Tanya Phillips or Jim Shames are here, but I would like to turn it over on our updates, if possible, to our statewide partners, Andrew Swanson. Andrew, if you have an update for us, and then we can maybe see if Dana's audio works before we go to our local partners.
Thanks, Eric. Hi, everybody. It's good to see you guys, and I apologize for missing last month's meeting. So I have some legislative updates. I'm assuming you all have been briefed on the Oregon Health Authority, legislative agenda, what they're proposing? No? Okay. So there's a couple that I think everybody on this call should be aware of. HB 2086 increases access and quality of behavioral health services. So I think it's specifically focused on health equity relative to behavioral health services. And again, these are the OHA bills that you guys might want to take a look at. Senate Bill 67 improves treatment of co-occurring disorders. So of course, mental health and addiction issues. And then SB 69 would expand recovery housing for harm reduction. So I think the thing there that they're talking about is, there's a lot of abstinence required recovery housing available, like Oxford houses, but there's very little capacity for folks, practicing a harm reduction model of recovery. So in addition to that, Oregon Recovers, we have a variety of bills. I know I've touched on this a number of times in the past, but the Addiction Crisis Recovery Act is kind of the big piece of legislation that we've been working towards for the last 3 years, really. And it would raise the price of alcohol to by 20% as it stands now, to reduce overall consumption by upwards of 10%, but then significantly reduce binge drinking, underage drinking, and alcohol mortality, and generate $746 million of new revenue that could be dedicated to funding a new recovery-oriented continuum of care as directed by the Alcohol and Drug Policy Commission's strategic plan. So that's obviously an enormous lift. It's going to require a lot of effort and a lot of, it's going to require bipartisan support and a really broad coalition. I've been actively building that coalition over the last few months, and we have quite a robust strategy table that includes the cities and the counties, a lot of healthcare providers like Kaiser, hospitals, the Oregon Council for Behavioral Health, the Oregon Society of Addiction Medicine, and a variety of others. And now we're kind of at the point where, it's going to be a remote legislative session, which puts advocacy groups obviously at an inherent disadvantage relative to industry lobbyists because our power's in numbers and we can't turn out at the building. So I'm working right now to organize kind of a statewide advocacy campaign. And so if any of your staff or if you guys at all are interested in volunteering some time and advocating with us in your own personal time or for your organization, I'll put my email in the chat here. And you can just ping me and I'd love to set up some time to brief you. Additionally, the other bills that we have in this session all kind of work in tandem with that. Larger bill is we have a recovery center bill that would create a network of recovery centers around the state. It's kind of our backup contingency bill. Currently, it uses unclaimed bottle bill money to do so, but we've got a meeting tomorrow with Ledge Council to figure out if that's possible. Also, Rep. Prusak, who's now chair of healthcare, is carrying a bill that would require warnings at establishments that sell alcohol. Basically, kind of like, currently they have the warning about raw food on menus. Similar situation there that have to have a warning relative to the addiction and cancer causing risks of alcohol products. This is, of course, part of our larger public health strategy here because it forces the alcohol industry on the defensive in public hearings, against the fact that their products do cause addiction and cancer in some proportion of the population. Also, Representative Solman has a bill that would require the Oregon Liquor Control Commission's makeup moving forward over the next 2 appointments to be 25% coming from public health or alcohol and drug prevention. So currently it's mostly industry people, alcohol industry folks. And so we want to start seeing a more public health minded lens there at the OLCC. And then Senator Dembro has a bill that would eliminate the monopoly that the beer and wine distributors have over the producers and the retailers. It's super wonky, but ultimately what it does is it allows the producers to work directly with grocers. And from our perspective, what that does is it allows us to drive a huge wedge between the distributors, the producers, and the grocers, which are the fundamental 3 pieces of opposition to our larger Addiction Crisis Recovery Act bill. We're poking a big bear there, and that's the intention. And so that's, a quick rundown of our bills. The only bill number I have for us right now is House Bill 2758. That's Rep. Solman's bill to change the makeup of the OLCC. The rest are still in Ledge Council, so I'm waiting for drafts. Happy to take questions. I know that was a lot.
Andrew, I have an abstract question. I hope you might be game to address it.
Sure.
If you were to give the USA Today version of what the state's response to the outreach and and treatment requirements of ballot measure 110 are, what is your interpretation of what that looks like? And without getting too wonky, if possible.
Sure. Yeah. And so I'm not, as a lot of you probably know, Oregon Recovers opposed ballot measure 110. And so we've not been very involved in the subsequent conversations because there's a lot of tension there. But my understanding in conversations with people that are very much involved over at OHA is it's not been a very smooth process at all. So I know that, and I hope some of your members actually applied, but I know that the applications were open and for the Oversight and Accountability Committee, and that decision should be coming out shortly. But as far as I know, they don't have much money, if anything, to play with in terms of the grants that they're going to be doling out for this year. The governor's budget is recommending that they postpone the implementation and investment in services part until 2022. But OHA is really actively trying to at least get things going at some capacity this year, because obviously, as you guys know, the decrim part kicked in December. So we've eliminated a pathway to treatment and recovery for a certain swath of folks that are engaged in the criminal justice system now. And so absent any other kind of intervention and engagement, that's just going to have the net effect of less people engaging in treatment and recovery. So we're, like everybody else, we want to see the implementation part very successful. But it's my understanding it's been kind of a rocky and very slow start. I don't even know if they really have officially appointed leadership to that committee at this point. And as far as I know, no one's heard back about appointments yet.
Okay.
Yeah, so not great.
Well, I think we knew it would be a tall ask to get that stood up when it was on the ballot. So this is certainly time is of the essence as people are going to be hurting, and as we see, unfortunately, overdose numbers looking worse in our communities. Certainly, the response is paramount. So let's see, Dana, were you able to get your audio working? Is there any way you can give us your piece real quick, or not real quick?
Can you hear me?
Yeah, it sounds good. Thank you.
Okay. Well, thank you, Andrew, for giving you kind of did a little OHA update for us too. So thanks for that. I wasn't planning on an OHA update, so I don't know exactly what I have to provide. I can touch base on the ballot measure 110 a tiny bit. As Andrew kind of brought out, that we are really close to having that membership finalized. This afternoon, actually, leadership is looking over the list of applicants. So thank you if anyone from your community applied, we really appreciate it. So letters should be going out soon, and we are on track to have a February 1st kind of effective date for having the Oversight and Accountability Council established. The other date within the ballot measure was standing up the temporary addiction recovery center, and that was awarded to Lines for Life, and they are getting that started, and we'll have a phone number out to the law enforcement partners so that they can give the phone number to individuals that have been cited that need to have their citation waived. So that is getting stood up pretty quickly. So look, we do have a web page for the ballot measure where we're anticipating putting information, phone number, and what to expect when calling into Lines for Life to obtain a health assessment. Also, Lines for Life at that time will provide some peer-delivered services, some case management services, if that is kind of requested or outlined within the individual intervention plan. We did also contract with an outside vendor to help do some facilitation work with our Oversight and Accountability Council, and as well as do some project management. So it's a big lift, as mentioned and as known, and so we're trying to hustle to get all the moving parts ready. We also have the proposed delay in the from the governor's budget, which is kind of complicating things, especially when we had to stand up a temporary addiction recovery center by February. So what we're doing is we're just looking at our spend plan to see one, how to get the Lines for Life contract funded. Also, we are looking to see if there's any grants that could be awarded under the Community Access to Care section of the ballot measure. So we're doing a lot of kind of behind the scenes work, which hasn't quite been communicated out public facing yet, but we are working to get as much information out as soon as we can, and as soon as we're organized enough to kind of share that in a way that's beneficial and meaningful to everyone. So that's about it from me.
No, that's very helpful. And Samantha Byers had sent me a couple notes as well, just to tack on to the Measure 110 response, that there's a lot of internal work related to racial equity and health disparities as it goes towards behavioral health, and that's falling under the 110 umbrella. And it is also the work of Ballot Measure 110 to align its work with that of the Alcohol and Drug Policy Commission, which finally started to take shape and get some muscle behind it and actually look for some tangible goal setting. And I know Andrew, Oregon Recovers, is that it right there as you show it up there, was a big part of that. of that framework, because the Alcohol and Drug Policy Commission had existed in name for quite a while, hadn't met for a number of years. Oregon Recovers went in and started raising a ruckus, I believe that's the official term, saying this needs to be an important and functional body. And from that point, they started getting some real work done. So hopeful that the work that they've done will align with the 110 initiative there. Samantha Byers also mentions that CARES funding was extended so that recipients who did not have enough time to complete the work by December 30th can have until June 30th. And for SOR, that's the opioid response money and funding. MAT expansion across the state remains a priority. So that means looking at our OTPs, looking at other areas and innovative ways that people can have access to MAT. And HIV Alliance is leading the Prime Plus effort in Jackson County. I'll let Dane give a full update on that officially, but we can wait until we do local ones on that, Dane. So I won't give it short shrift, I promise. And also Project Nurture is starting at a statewide level. Dr. Hecox and Oasis Clinic are leading the charge in Jackson County. Of particular excitement, these are her words and I share them, is the likely National Institute on Health grant secured by OHSU to study and evaluate implementation models and outcomes over a 5-year period. So great to see the Oasis Clinic getting that kind of support. So thank you to those two state partners. I do see that Dr. Mann is here and he is our featured speaker today. We're going to talk about contingency management. And you've heard my spiel at a number of these meetings where contingency management is one of those things that I think we've bandied about inappropriately in our line of work where we say, we do that. Absolutely, we do that. But we haven't done it with fidelity. We haven't done it with regularity, and we haven't seen the outcomes that it can really bring. So the hope was that we would bring in an expert to talk about contingency management, what it can mean, how it can be important within substance use disorder work, within behavioral health work, and who better than our very own Dr. John Mann. So Dr. Mann, if you are ready to take over and be our presenter, we're very lucky to have you today. So thank you.
And how long do I have today?
You officially have 45 minutes, but if you need a little more, yeah, we can figure it out.
That should be good. And sorry I wasn't here when you talked about inviting me last time, so I'm not totally sure. I think you gave me a good introduction of what might be helpful here, and so I just want to let you know, if you feel I'm going down the wrong route, feel free to redirect, call an audible, I can do that. I do have a presentation that I've given a number of times that I can give here today that talks about just really what contingency management is and how to set up a program. If that's too nuts and bolts for anyone on the call and you want to talk more about some of the policy implications, I think we can touch on that as well. But do you feel like it'd be helpful to lay kind of a groundwork first and talk about what it really is?
I personally do, because I think we've heard, I think it's one of those things that gets bandied about. Well, we're like, oh, we've got a rewards program or we've got this. And it's really, I think it's a little more substantive than that. And I think at least having a baseline understanding of where it comes from, what it is, I think it would be nuts and bolts would be great.
Okay, well, let's do that.
Is that fair? Okay, thank you.
Can you see my screen? Okay, good. So, what is contingency management? And really what at its core, it's an evidence-based approach, helping people change, right? And so usually when we talk about it, it's helping people follow through with some of the goals that you and the person have developed together. Often that's abstinence. Sometimes it's more harm reduction stuff. Sometimes it's not related to substance use disorders in general, but it's a way to help people change. And it's particularly helpful for substance use disorders because of some of the brain changes. I won't talk too much about the brain changes, but a little bit, because some of the positive results that some of the reasons to change just take a long time to actually achieve with recovery from substance use. And this is a way to bring everything closer in time. So I don't have any financial disclosures. I don't make any money from any of this. And I'm not going to talk about off-label use of medications. So we're going to talk about what is contingency management? Why is it a real behavioral technique? Why is it an evidence-based principle? Even though OHA has yet to recognize it as such, and I think that's one thing the LADPC can help change. OHA, you're on the call, I believe, still, hopefully. We're going to talk about a couple of different ways to do it, so that when you hear different ways of doing it in the community, that'll kind of like ping your memory, like, oh yeah, this is one of those ways. This makes sense. This is really contingency management. And I'll talk a little bit just about how I use it in my practice with our ACT team, Assertive Community Treatment. So, this is the big question. How do we help people change, right? We all want people to change. I think we're all used to being able to tell people to change, but how do we really help them change? So, in terms of recovery from substance use disorders, many of the benefits like better health, improved relationships, being more productive, those are such big things, and they take a long time to really achieve. When you're working with someone who's maybe still active in use or really early in recovery, telling them that if you change, your life will be better is really abstract. And so what contingency management does, it really brings benefits to the immediate term so that people start to see benefits of pro-recovery behaviors immediately. And why can't we just tell people to change? And why don't people just say, okay, I know there's this lifelong goal and it will be better for me. Why don't people change? It's kind of like asking everyone here, how many servings of vegetables do you eat a day? How many times a week do you exercise? We all know, we should be eating a lot more vegetables than we are, and we should be exercising probably more frequently than we are. But so many of the benefits and consequences are such long-term that it's easy on a day-to-day basis to not make those changes. And it's the same with substance use disorders or other things people want to change and have long-term goals. So, there's plenty of reasons people don't change. We know this, right? Like I talked to a patient today who wants to stop using methamphetamine, but is having trouble visualizing it because he feels that it helps him stay active, which is a distractor from his chronic pain, right? That pain is very immediate. And some of the benefits from stopping methamphetamine use are kind of abstract and long-term for him. So, really with contingency management, we're trying to treat fire with fire here. The benefits for people, right, intoxication, are very immediate with substance use. And so what you want to have as one of the behavioral strategies in contingency management is something that has positive benefits from day one of pro-recovery behaviors, right? So you got to make those benefits immediate. You got to make sure they're happening right now. You got to make them noticeable or salient. And you got to make them rather predictable. People got to know that things are going to get a little bit better if I do this. So if I do this, then that happens. That's the kind of the basis of operant conditioning or instrumental learning or operant behavioral principles. And those are the behavioral principles that underpin contingency management. And they're a little bit different than another set of behavioral principles you may be more familiar with called classical conditioning. And that's the pairing of two non-related stimulus. That's like traditionally we think of, hearing a bell and salivating. So if you ring a bell when you give someone food every day for a week, right, then when they hear a bell, they might salivate. Do they really know why? They don't necessarily know why. That's not what this is. Operant conditioning, people know, like if I do this, then this happens. If I do this pro-recovery behavior, something good happens immediately, saliently, and predictably. So we're not the only ones to know this. Who's seen this sign in our community? Yeah, Eric has.
I've driven by it. I didn't know the spin and free spin though, right?
Drives me crazy. So the dispensaries know this. This is literally, I took a picture of this. They know what they're doing, the chance that a free cannabis entices someone to go in, and if they win it, they're like, wow. The next time they walk by, they know they might win. If they've won in the past, they're going to walk in and take another spin, right? We have to be at least as good as the dispensaries in helping people change our behavior. That's my challenge to everyone here. Be at least as good as the dispensaries. And we got to move beyond just telling people to change. We got to really help bring some of the pro-recovery benefits more immediate in time. So here's an example. This is a wheel we've used on our ACT team in my practice. And it uses immediate positive reinforcers to improve adherence to treatment plan elements that otherwise have mostly really long-term benefits, frankly. So, I'll talk more about this wheel, but you see it's got some points on there and a lot of positive feedback, because I really believe in the power of positive feedback. I think a lot of the people I interact with have heard a lot of negative feedback. I think they've heard over and over how they're not meeting expectations. I think, if you go back long in their history, they maybe never had a parent even that really told them they were proud of them and they'd done a good job. And I think using those words and really meaning it goes a really long way in helping people change. So immediacy. So what's that really mean? Who's heard of a SMART goal? SMART, right? Specific, measurable, achievable, relevant, time-bound. That's the perfect kind of treatment plan objective to think about when you are choosing how to institute a contingency management program. You really want to target an element of a treatment plan or an outcome that is specific, measurable, attainable, right? Not like be a better person. Not don't overdose in your lifetime. Not be sober for the rest of your life. Something that you can measure on a day when someone comes to see you. So examples are like attending a group. For a lot of my clients who I'm seeing for schizophrenia, bipolar disorder, they often have coexisting substance use disorders, but they're not necessarily there to see me for a substance use disorder. And so, when doing some of this work initially, I might have as one of the treatment plans successfully just providing a laboratory sample, regardless of the results. So like a drug screen, I might be pretty excited for them, like, hey, that's awesome, you did that. And that way we can reframe the whole relationship with things like drug screens from being something where someone has a chance to fail to something where someone has a chance to succeed just by doing it, even to begin with. So that I can have that conversation with them. Tell me more about this, tell me more about your use. And then it can be for someone moving beyond that, we're really helping with appropriate urine drug screen results, say like one that shows they haven't used methamphetamine in the last couple of days, that kind of thing. But you can choose for yourself what behavior is someone wanting to change, what's something that's, measurable and attainable in a short period of time, and that you can reinforce in this way. So, often, so we talk about, reward programs or reinforcers. People have to value the thing you're giving them. Does that mean it has to be expensive? No, it doesn't. But it has to be something that someone actually wants, So examples are like, I had some colleagues doing a contingency management program for adolescents, and they initially thought, what do adolescents want? And they had CDs, and the kids were like, what do we even do with these, right? What are these really? And so you got to know your audience. They got to be things people really want. Like I'd obviously rather give like health food to people, but people want snacks, and so, make sure this is something people want. You can also allow people to bank points for larger items they would like. And I'll talk a little bit about kind of what we started with and what we've changed to, partially because of pandemic, partially because of other things that just work better for us with certain limitations. So this is kind of the big branch point in thinking about setting up your own or understanding what a contingency management paradigm might look like when you encounter it in someone else's treatment program or in the community. The first real branch point to think about is how you're going to reward people. And so you can use a fixed schedule or an intermittent reinforcement paradigm. Fixed is people get the same amount every time. So an traditional example of fixed is like a gift card, right? Who's used gift cards? I bet people have. An intermittent program, someone gets, for every time, like instead of every time someone successfully does something, they get a spin of the wheel. And they may get positive feedback, they may get a low number of points, they might get a higher number of points. And we'll talk more about what the difference is there. So you'll see on mine, ones I've used, about half are positive feedback. There's 400 point slots. There's, 200, 300, and is there 500 on there somewhere? Yeah, 500. So they work equally well, but as I'll show you, if you hang in there, and feel free to let your eyes glaze over when we get there if you really don't care. But they work equally well. The intermittent is just a little cheaper to run. And if that's important to anyone on here, it wouldn't surprise me. There has been, you hear some people worry that, oh, isn't this kind of like gambling? Well, there's no wager, so it's not. And it's been shown to not contribute to the development or reinstatement of a gambling disorder. It's fun. People really like doing this, especially in groups. People love, not that we are doing groups in person anymore, but having this at the end of a group, people really cheer each other on. It's like Wheel of Fortune when it like almost gets to the big 500 prize, but then it just doesn't, it goes just past it. People are like, it's a whole emotional roller coaster, and people get very excited for others, and it can be a great group experience. Prizes can be vouchers or tangible rewards in either one. The second branch point is to do what's called a constant schedule. And that would just be every time someone does the thing, they get one spin or they get one card. It's the same every time. An option would be an escalating schedule. And this just helps it work better. It's a little bit harder to keep track of, but if you can do it, it really helps it work. And an example would be, say, this helps people do that good thing more times in a row without wanting to skip. So if the example is you're reinforcing people for appropriate urine drug screens that don't show any evidence of methamphetamine use, say you're doing those weekly, the first week someone gets one spin, the second week it's appropriate, they would get 2 spins or 2 gift cards. The third week in a row without missing, they would get 3 spins up to whatever your max is. And this really helps it work. People, once they get up to like higher numbers, they really don't want to miss it. So here's kind of an example of the constant schedule. You do one, you get one. You miss one, you don't get anything. You do one, you get one. You do another one, you get one. You miss one, you don't get anything. And the escalating schedule, just in contrast, right? The second time you do it in a row, you get like 2 spins or gift cards. And then you can get up to like 5 and then kind of cut it, But once people get up with the escalating schedule, once people have done something a couple times in a row and they're really seeing the benefit of it, this immediate and salient reward, it's a big thing, they're that much more excited and motivated to continue maintaining that improvement. So how long, I get this question a lot, how long do you continue, And I would say, wow, continue keep going until at least as long as the long-term benefit of the behavior has been realized, right? You often start to see people, 3, 6, 9 months, a year, kind of achieve different levels of being pretty stoked on their life, right, with recovery. And you got to kind of at least help people get to that point where they're getting kind of stoked on their life in recovery, to start thinking about not doing this kind of contingency management anymore. It might be a long time, but why not? If it was worth it to start, it's worth it to continue to help people get there. The longer people practice pro-recovery behaviors, the more it becomes ingrained and a part of their life, and the more likely they are to really achieve some lifelong recovery or, change towards harm reduction based changes in their life that helps them live a better life or a longer life. So I talked about my ACT. I don't know if anyone here is unfamiliar with the ACT model. It stands for Assertive Community Treatment, and it is specifically written into law in Oregon, although it's not an Oregon-specific kind of program. We're a medium-sized ACT team. Everyone has a diagnosis of schizophrenia, schizoaffective disorder, or bipolar disorder for the most part, and diagnoses of methamphetamine, cannabis use, alcohol use disorder are pretty common, probably 75, 80%, and often complicate response to treatment. In addition to anyone accessing specialty mental health services, their most likely cause of death will be related to tobacco. So I firmly believe, it's part of our job to help people quit using tobacco, alcohol, and drugs. And like I mentioned earlier, a lot of people, they're not there for substance use disorder treatment. And so how do you really engage that population? And so you got to make it salient and fun and something people want to do. So contingency management is pretty well suited. It costs about $10 a month per person. That's not a whole lot. And it's really made a big difference, in my opinion. Kind of looking at group attendance pre and post starting this program. These are pre-pandemic numbers. Our men's group increased from average of 2 people to 9 people. Our co-ed EIMR group increased from 4 to 14 people. Our women's group increased from 4 to 7. And remember, this is the average cost of only $10 a month per ACT client. We initially used candy and snacks, but our building people found out, and so we're not really allowed to keep candy and snacks around. So we changed and doing mostly points and vouchers. Some people, really dug being able to bank points. I really think that immediate rewards are really helpful, but for people who really wanted to work towards things, bigger stuff, basketballs, CD players, headphones, that kind of things, they can bank points and save them. 500 points is $5 gift cards. So 100 points is about $1. It's tracked in Excel. Most popular gift cards are Walmart, Dollar Tree, McDonald's, Subway, Taco Bell. And if you're going to use gift cards like that, just make sure, if you are buying them from Walmart, that when you purchase them, you can select that they're not redeemable directly for alcohol or tobacco. You'll notice I didn't talk about a fishbowl technique. Who's heard of the fishbowl technique before? Yeah, that's pretty common. I never really wanted to have to worry about people going to the craft store and buying beads or tickets or anything and having to keep up with that kind of thing. So it's not a model I generally recommend for ease of use in an outpatient setting. Inpatient could be different and people don't have access to go get stuff like that, but I just never really wanted that dynamic as part of our treatment, wondering, are people bringing in a gold bead or that kind of thing? Who cares? Who wants to who wants to learn about budgeting for this? Anyone? Or should we kind of skip through that and get to questions and discussion? Eric, what do you think?
I think we could probably skip through.
Yeah. If you have questions about budgeting, I can send you this. It's kind of, basically you just have to figure out how many people you have. What is kind of perfect behavior, what does perfect behavior look like? And then figure it's going to be less than that. And just to give you a rough idea, the intermittent, the wheel kind is about half as much to operate as the fixed kind. And using an escalating schedule is more expensive, but it works better. Okay. What questions do you have?
I read in a newspaper article, so how's that for a respected journal, that contingency management was especially effective with methamphetamine users. Is that something that is backed up or something you've seen?
It's especially effective compared to the other treatments. So, I wouldn't say that it's like, oh wow, it works way better for methamphetamine use disorder than opioid use disorder. It's just that for opioid use disorder, we have medications that work really well. And for methamphetamine, we don't. So if any of you have heard, there was big news recently about a trial that showed some positive response for methamphetamine use disorder, combination extended-release naltrexone and bupropion. Just to give you an idea of the relative effect sizes, contingency management works about 5 times better than the medication, and that's the best medication we have for it at this point. It works a lot better, and there are no side effects, and arguably it's going to be cheaper. I mean, that medication combination is, it would be about, $1,400 a month. So it's cheaper and it works maybe 5 times better. To give you an idea of like taking buprenorphine and methadone out of the equation. So we're talking about those two for opioid use disorder. They're on another level. They work really well. For pretty much any other medications for substance use disorders, you got to treat about 7 to 9 people for one person to benefit. And it's not like that one person is cured. It's the medication helps a little. So, the response to most medications for substance use disorders, whether it's, tobacco use disorder, alcohol use disorder, it's kind of on that level. You have to treat about 8 or 9 people for one to really benefit. That's a lot. And contingency management, it works for far more people. It's much cheaper, and the effect size is about 5 times as great. So someone gets 5 times as much benefit, that one person that does benefit. It really helps, in other words. Now, I'm surprised I haven't heard anyone say, some of the more stigma-based responses, you'll hear that, I'm sure no one on this call is feeling this way, but I'm sure you're talking about it maybe in other settings, and you hear someone say, but isn't this just paying someone for a behavior that they should be exhibiting anyway? And I say, who cares? I mean, this is our job to help people change, and we should be looking at what helps people change the most. I think that perspective really is based on moralism and really underscores or really undermines the message that these are illnesses that deserve treatment, frankly. The biggest, as I mentioned earlier, one of the biggest difficulties right now is that it's not yet recognized as an evidence-based treatment by OHA and therefore Oregon Medicaid, right? So how do you really pay for it and reimburse it? Our ACTS team is funded in kind of a specific way. We get a certain dollar amount to provide treatment for a person for the entire month, no matter how much treatment they get. So I feel very, very confident in our ability to do that, because if people come to me for more treatment as a result of contingency management, we're not getting paid anymore. We get paid the same to do more work. But, some of the complexity is, how do you make sure people are doing this right? And it's not just a kickback, right? In the age of body brokers and kickbacks. And I don't have a good answer for that. This is where some oversight of clinical excellence needs to occur, and people need to just be good service providers. But it's that's some of the complexity and why it's not yet recognized, and why some people have trouble getting it paid for. So someone had a question.
Hey, John, this is Stormy. I'm wondering what does this look like during the pandemic for you guys?
Yeah, pandemic has changed things that don't really use the intermittent schedule anymore. So gone really to voucher based. Primarily with ACT, ACT still is a lot of distance, but in person, and so it's outside, 6 feet away, wearing masks, my appointments are mostly telephone. So it's mostly gone that direction. So we're not doing the wheel as much as kind of how pandemic has changed things.
Do you think it would still hold to fidelity if you spun the wheel maybe on the screen with a patient and then sent them the voucher or the prize if that hits? Or would that be too far off? Is it too delayed?
Kind of have to ask people. Like, if they're not stoked on it, then that's your barometer. You know what I mean? People have to be stoked on this. And if they're not, do something different, I think is kind of the message.
Thanks.
Yeah.
John Boehm.
Dr. Mann, I just wanted to thank you for that presentation. I want to thank everybody in the group for hanging in there and listening to this. As a frontline counselor, this information is invaluable, and because we see it every day with motivation from clients, and it's nice to finally, maybe not finally is the right word, it's nice to hear people openly speak about not just doing the same stuff that we've done over and over and over again for years, and to see people with lives on the lines, to get creative, to try different things, and to see how we can help. I stand 100% support with that, and it's glad to hear that we're having these kind of conversations.
Yeah, I mean, if you look at all the data on tobacco use disorder, how do you get people to quit tobacco? The absolute best the studies with the absolute best results, including medication, everything, is contingency management, where they just paid people to quit. Now, I think that as providers, we have to tuck our ego in our pocket, and really just understand, like, well, what I care about is that people get better, and that's really all I care about. If that's what helps people get better in the long run, that's what helps people get better. But for anyone who's taken on a huge lifestyle change before, whether it's recovery from substance use, recovery from mental health, whether it's recovery from a physical injury, whether it's just minimizing your risk of chronic disease and illness, obesity, is huge, and really taking some of those first steps and sticking with it in that first month, 2 months, 3 months, until you start to see some of the actual rewards from the change, the intrinsic rewards. Because as anyone who's a runner or gotten into running knows, that first month stinks. Maybe you really get into it after that, but you got to have a reason to be doing it. Out. And this is just the same thing, And just do it doesn't work for everybody, so especially when the perceived benefits of not changing for people who are currently using substances is so high.
Well, Dr. Mann, to tag on to John's comment, I think it's also important to hear contingency management, particularly as you present it. I mean, you've got a prescription pad, you've got master's level counselors you work with, you've got an army of peers you can use, and you're like, and it's important to have a wheel to spin. I mean, not to make it sound so glib, but within a clinical context to say this is also a very important intervention, I think gives it some weight.
Well, I don't want to. Who do you think's doing all this work? Frankly, it's our therapists, CADCs, and therapists are doing a lot of this work, and it's important that they understand it. And definitely, education has been a big part of this.
Eric, this is Mike O'Malley. I'd like to thank you, Dr. Mann, as well, and also report that I've just done a fair number of CARF surveys, accreditation surveys in the state of Oregon for ACT programming in Bend and Portland as recently as last week. And I suspect that because of the outcomes that I saw and the measurement in those programs that I surveyed, that ACT is going to be much more accepted, and hopefully insurance companies are going to see the value of it sooner rather than later. It's really, really excellent, particularly, as you well know, for people who have severe co-occurring disorders. So thank you for that great presentation and the simple way you described it. It's been around for a long time. And the only other thing I'd say is that we need to inject more excitement into treatment. And this does allow for excitement. And of course, obviously, if you as the provider, or if I as the provider excited about spinning the wheel too, then that, of course, reinforces that behavior for the client. Thank you again.
Yeah, of course. And I think when you look at, psychotherapy research written large, there's maybe just two or three broad themes that really come across, what helps people get better in terms of behavioral interventions. And that's that the relationship's intact, right, between provider and client, provider and patient, provider and participant. But then two other really big pieces, and that's that the provider thinks the intervention is going to work and the client thinks the intervention is going to work. And, I think the data, if you really look at the data, we've all heard contingency management works. It helps providers get jazzed about the work. They think this is going to work, especially when it seems very difficult otherwise to treat methamphetamine use disorder in Southern Oregon. And I think that the clients really feel that this works because there's that immediate positive response. And so you have the basic elements of what helps any psychotherapy work. They're pretty face valid. Now, I do want to mention what contingency management isn't, and you'll notice this was all about reward and positive feedback. And I want to be very careful that I think some people use the term contingency management to refer to a system where people are somewhat punished also when they don't meet expectations. And I think it's really important when you're setting your program up that it really is all about positive feedback. I'm not saying you have to give people positive feedback for behaviors that aren't pro-recovery, but just to make sure that what this really is noticing when people are doing the right thing and giving them good feedback about that, whether that's verbal or in the form of something of extrinsic value.
Dr. Mann, this is Lisa McCready with the treatment courts, and we have been, utilizing the rewards and sanctions program, but I think that we utilize more of the rewards than sanctions, and we do use the fishbowl approach to rewards on a frequent basis in our courts, and applause is a daily incentive I would see. And I'm curious where you, and suggestions of funding for your incentives and creating the contingency management program. Because funding is always an issue with any program, and to be able to, pay for the gift cards and all of it is difficult for a lot of programs. Do you have suggestions? And thank you for your presentation. It was wonderful.
Yeah, of course. Like I said, this is kind of difficult because of the restrictions on how Medicaid and Medicare dollars are spent, and that it's not an improved evidence-based therapy. And I think one thing that the LADPC can do, that Oregon Recovers can do, is to advocate to OHA that it is recognized. The evidence base is so clear, right? So clear for it being an evidence-based therapy that would open up Medicaid dollars being used to fund it. Right now, you really have to rely on, like I said, in the ACT program, we're somewhat capitated, so we get a certain amount of dollars to treat someone. And I think this is how people get best, how people get better, for several of these illnesses, the best way. And so, but how do you get it funded otherwise? It's kind of grants. You can ask CCOs for grants. I know, there have been some small grants from JCC to several of the entities on this call. I don't know if they have money left to do that or what their appetite is. But man, it's like one of those things. I hate to say it, but we're like doing bake sales for addiction treatment. We're still in that zone. I have no good.
It's crazy because this incentives and sanctions have been around. It's a 10 key component of our drug courts, and it's been around for years. And it seems crazy that we have to, specify that we can't use incentives for specific things. But I mean, that's.
It is crazy when you consider how expensive. When you consider how expensive it is to sanction somebody. In the criminal justice system, to put them in the transition center, to put them in jail, that's expensive. And if instead we invest a fraction of that amount into helping someone get better, to the point where they didn't need a sanction, that's where the money comes from. But how do you ever show that? It's very difficult, as any intervention is difficult to show. But that's where the money comes from, is savings from having to sanction people. So I guess, you do a pilot project funded by bake sales, and then you show that it works, and you show how much money it saved, and then you ask for that amount of money instead to make the program bigger. It's sad, I think.
And I still think there's that moral hiccup folks have about, so this guy gets McDonald's for doing what the court says he has to do. That's what we're going to, I think people can't get over that piece. But I don't think people really like spending, $100 a day for an incarceration episode either. So, yeah, it is a tough one, but it's important to get that message out.
I think with our courts, if they saw that people a lot of times have the option of taking their incentives and applying it towards their fines or their probation fees or their restitution, then they would see that they're actually not actually getting the McDonald's, but they're actually applying it towards, their fees. So,
and I can't tell you how well that would actually help them change behavior-wise. I don't know that it. Some of how the brain is changed to be so. The brain changes as a result of development of substance use disorder towards a machine for seeking novelty. In many ways, and paying off a fine isn't a very novel experience. And I don't know if it will develop the neurochemical salience of someone attaching importance then to that thing, right? The reward, like when we talk about it being valuable, it's got to be something that tickles the brain in just the right way, that they remember the reward and associate it with what they did, so that they want to do that thing again to get that thing. If I do this, then that happens, right? And I don't know if I'd do anything for someone to pay $5 off my student loans, because it's such a drop in the bucket. But I would do a lot for a $5 gift card to Starbucks. I'm just saying. And yet that's the same amount of money. That's $5, Think about, for anyone here who has a mortgage or other giant debt, what would it take for you to get $5 off of that giant debt versus get a $5 gift card to your favorite anything? It's different, even though it's the same amount of money. And so our job really is find what is that thing that our small amount of money that we're investing gets people the most excited about. And so, whether that's a 20-cent miniature Snickers bar or a king size candy bar that's $1.39, you know what I mean? It's amazing. It's really not about the dollar value. It's about what tickles the brain to help people associate that thing with getting stoked on what they did. And that's the real key in terms of how to, the rewards and contingency management. And then the other piece is just really being consistent, making sure you always do follow through with that.
Dr. Mann, this is Joanna with Medford Treatment Center, and I wanted to kind of speak on this a little bit too. We actually just went through some training on contingency management as we're gearing up to roll out our program next month. And one of the biggest pieces in the training is really linking their values to that reward and having them look at the benefits to it. So for us, we've looked at a couple of different gift card options to a couple of different vendors, one being Dutch Bros, but others being Walmart or Fred Meyer's, where they can get groceries. And we've talked about how we can look at how we could draw that from the treatment plan. So, if they are struggling with their health and they're having, poor eating habits and things like that, in discussing maybe choosing one of those vendors where they can actually get those, and so I think it's really important from a clinical aspect to pull out that with the client on their values. And that also brings up a really good discussion too in a clinical setting on how these rewards can benefit them in the long run.
If they're excited about it, I think that's kind of the biggest issue. So if, I think cross-culturally, this can be a huge piece of leverage. Yeah, people really want to see themselves as the provider, take care of their family, then definitely gift cards to groceries can be a huge piece of that. It's really, there's no one size fits all, I don't think. It really is about individualized treatment and knowing what someone cares about, like you say, what's their values, and helping work there. But yeah, as long as it's something people are excited about and not something people just should be doing, like if people aren't buying groceries for their family, but they really don't care about that, I don't know if I would pick a grocery gift card for that person necessarily, even though it's what they should be doing. It's kind of getting away from what people should be doing and really focusing on what are people stoked on.
Right.
Pro recovery, but exactly what I think you bring up in terms of value assessment. I think individualized value assessment is important in identifying those things. Like I said, adolescents don't necessarily value CDs like we did when we were adolescents, right?
Well, and Joanna, just to tag on to that, Kelsey Smith Payne from the Oregon Health Authority was the one who was so excited talking to me about Medford Treatment Center utilizing contingency management. And I was kind of, I mean, I hate to admit it, this was just a few months ago. I was like, okay, great. But no, she goes, no, they're going to do it to Fidelity. This is going to show great results. And so I decided to try and do something about my ignorance. And talking to Stacy Brubaker, she mentioned that Dr. Mann was not just a proponent of it, but also somebody who could teach us on it. And so I think it's exciting that it's gaining, again, that clinical gravitas to really make change in our community. And so it's exciting to see. And I think, you know, I don't think it can exist in a vacuum either. I think if we treated people poorly, if our agency's not person-centered, if we're not trauma-informed, and we think that we can just utilize a contingency management program to try and create buy-in, to try and help clients obtain outcomes, I don't think it's going to be as successful. So I think having it, you know, as part of a greater strategy would be really helpful too. But
when I worked in a different service here at the VA, we used contingency management to increase the participation in community recovery meetings. And like some of them were affirmations, and other prizes that we gave was recovery literature, not just 12-step focused. And then there was one big bang of $100 in canteen bucks, and that really got them going. And like you said, it was a lot of fun on Fridays to do that.
Yeah, and so that's kind of what I was hoping to do with kind of describing some of the different models, was then you could like hear about that program and be like, okay, yeah, so that's an intermittent schedule of contingency management. And that's a great example of how to run a program pretty affordably. If you listen to the things that you guys gave out, right, there was that one really expensive thing, and everyone's pretty stoked on that. And the chance to maybe get it is kind of the thing that you win. But if the average cost, you know, is much lower than like giving a gift card to every single person, but that chance to get that big thing, that's like the 500 point thing on my wheel, you know, that's kind of how it works. It works about the same as just the gift cards, but it's much cheaper to run. So, and the VA has really stepped up in the last, I think, 5 years with contingency management. They probably are, I think I read somewhere recently that they're using it in like 96 stations across the country, some form of contingency management.
Yeah, that's true. I just to add a little bit, about 10 years before the program that Heather just described at the VA, we had a sort of a contingency management. We did some follow-up, and we paid veterans $10 to call us back every time they called with 30 days, either 30 days or 90 days out. They got a $10 gift card. And we had some pretty good numbers of folks. You know, prior to that, we had maybe one or two people who would call us at 30 days out, and after the $10 reward, it went up to like 60%, 6 out of 10. So while it's not pure in the sense of the program you described or the later one that we did at the VA, if you're trying to get people to do things, as you said earlier in the presentation, paying them is a good way.
Dr. Mann, I have a question. I'm Nick from probation. Our wonderful director, Eric Dyer, has definitely implemented a lot of this into what we do. I run a domestic violence caseload that is more kind of criminal element based. And do you have any literature or information in applying these principles into the more criminal element versus addiction need?
Not offhand, but you know, it's not specific just to addiction. You know, it's really just behavior change. And you know, I think it seems pretty applicable there. A lot of the benefits, you know, the benefit of not committing a crime again is like you won't go to jail in the future. Like, what an abstract benefit in so many ways. And so, you know, giving people feedback, something they value, whether it's, you know, positive reinforcement or something of extrinsic value, you know, is going to help people do those steps towards changing their life, you know, maintaining those pro-social changes in this case. that have pretty abstract and long-reaching benefits. You know, it's how you help people change.
Sure. Thank you.
Thank you.
Anybody else with questions, comments for Dr. Mann? Well, Dr. Mann, I can't thank you enough. I mean, extremely informative, very practical. I think that in terms of SMART goals, all of us are sitting here saying, these are the things I can do now, or these are the things I can enhance or move. So it was everything we could have hoped for in this presentation. And again, I think as we all continue to come together, hearing about those successes in our community where it's working, little things that, you know, if it's not health food and if it's not CDs, you know, is it the Dutch Bros card? I think there'd be probably some shared capital in finding out what people really respond to. So thank you so much for your time today. Really appreciate it.
Thank you. Take care.
All right. Getting back to a little bit of business, Sarah Smith, if you wouldn't mind introducing yourself. You are a member and talking about your agency affiliation. I know you had told me that you were a little late with the mandatory training, but it's good to see you now.
Well, thank you so much. Yeah, I'm a nurse case manager at La Clinica's Birch Grove Health Center, which isn't really La Clinica's, it's a community collaborative. And so I'm there Monday, Tuesday, and Wednesday afternoon, and always interested in talking about our work in the community. And I have passions that the rest of you know about. I'll kind of button it there. Thank you, Eric.
That's great. Thanks. Welcome. And also, Lisa McCready, I believe your mic is working now. So for the minutes, if you wouldn't mind introducing yourself, you are a member and talking about your agency affiliation.
Hi, this is Lisa McCready with the Jackson County Circuit Courts. I am present.
Great. So to that effect, folks were given the minutes from December 16th of 2020. I don't know if anybody had a chance to read them, would entertain discussion. Hearing none, I would entertain a motion to approve those minutes.
Make a motion, Eric.
Nick Wrighton, motion to approve. Do we have a second?
I'll second.
And a second from Justin Hahn. All right. So I think the way we've been doing these minutes, Jennifer, to make sure they're approved effectively, is taking a roll call of membership to see where they vote on this. Is that right?
Sure, we can do that.
Great. Thank you.
See. Okay, Jack and Dory had excused absences. I don't believe Ron Dunn has showed up. Eric Dyer.
Approve.
Justin Hahn.
Approve.
Amanda Eisenhower. Okay. Rosemary Jernigan.
Okay.
Okay. Lisa McCready.
Approved.
Michael O'Malley.
Approved.
Heather Phil.
Approved.
Thank you. Nick Wrighton.
Approved.
Sarah Smith.
Approve.
Great, thanks.
All right. Gets us through the minutes. We've accomplished our business on that front. Next up on the agenda is local treatment provider updates. And let's go ahead and start with Reclaiming Lives, Stephanie and Brandon.
Oh, there we go. Hey, everyone. Nice to see you all. Thanks for that presentation, John. That was awesome. Good to see your face. We learned a lot, and it made me think, I wonder if we're all going to have the same spinning wheel, and wouldn't that be weird? I'm sorry, that was like the first thing that came through my mind. We might be reaching out, Nathan and Eddie and some of our partners, to see what you're doing so that we don't all have a spinning roulette wheel. On that, let's see, I do have a couple updates. Some people seem to be confused about whether we are open or closed. And so we are holding 10 recovery cafe circles a week in person. All of them are under 6 people. So we got distancing in our larger rooms. We are just not in the restaurant right now. So no coffee, no food, but we are open. And Brandon and I meet with people all week with 6-foot distancing and masks to talk about orientation and getting them assigned to circles. So if you have people who want to engage, we are open. We also have a lease on a building right down the street from us, 214 East Main, which is the former A.G. Edwards building, which is right next to Vogel Plaza in front of Ginger Rogers Theater or the Criterion or whatever you call it if you lived here for your whole life. So we are almost done with remodeling that and plan to open it in mid-February. Not sure where we will land on, open house for 6 doesn't really sound fun, but eventually maybe we'll have some kind of event. It will allow us to have daytime circles and some opportunities for a limited number of people to come in who may just need a place. It's membership still, but also just come in, get information, those kinds of things. So we're excited to have something street side. Right now we're upstairs from Rogue Organic Cafe and kind of off the grid. So to have signage and, a whole, wow, this place exists and looky there. So that's coming soon. We also are about to implement a Zoom circle for moms, which we will keep and continue moving forward with because we aren't able to offer childcare. So if you have women who have children that they cannot find childcare for to be in circles, we do have a Zoom option and an awesome recovery mentor for that circle. We just are getting ready to launch the 4th episode of the Recovery Survivors of Addiction podcast. So here's the little card. So Brandon and Christy, who are hosting the podcast, talk about different subjects each month. And the one that's releasing on Friday is titled, What Are We Recovering From? So it is found on most all podcast platforms, including Apple, Castbox, Google, iHeartRadio, SoundCloud, and Spotify. And if you haven't checked it out, we have 3 other episodes that we started with, which has been kind of cool to get feedback from people and see that kind of come into, help people really get some hope and just hear some amazing stories about how people do achieve recovery. So I know that, thank you, Rebecca or Jennifer. I'm so sorry. I do that every time. Jennifer for sending the link to the LADPC. I appreciate that.
And we've been getting a lot of good feedback on it too from a lot of people actually from all over the place. I didn't know that it was going to reach out as far as it had and as far as it's gonna, but holy crud, it's really making headway out there. So we've got a lot of good feedback on it.
Also, just in the last week, we updated our website to include all 48 of our Facebook Lives that Brandon hosted. So if you want to hear recovery stories or refer clients to recovery stories, those are all on the first page of the website. It's reclaiming-lives.org. So I don't know, there's a lot more video on there now and information about how to engage in a circle and what circles are like. So we just updated all of that. So if you're looking for real-time information about if we're open and what we're doing and what our contact information is, please go there. So do we have a minute for Brandon just to share a quick story about a client?
Quick story. We do.
Quick story. All right. It's been fortunate that I've been able to know a lot of people in this town. And about 10 months ago, a gentleman got a hold of me inside a prison, and he had about 2 years left on his set. Well, Governor Kate Brown released him early. And when he was released with no identification, no social security card. He didn't have anything on him. So when he got out, we brought him over to the office. We talked to him to figure out what his barriers are. This gentleman is a phenomenal artist. I mean, once in a lifetime type of person. I cannot explain to you guys. Well, we've had the benefits to be able to watch this guy grow and walk alongside him and help him out. He's now living in Oxford. He's been selling his portraits on Facebook, on Etsy. We set him up an Etsy account, didn't we? Mm-hmm. And it's just been phenomenal. The crazy movement that we've been able to do through these weird times and how we're not stopping or slowing down. I have a lot more, but I'm going to dumb it down for that for all of you guys because I know Eric's in a hurry.
I don't know if I'm in a hurry. That's an awesome story. And that, I mean, your guys' work, it really does transform. You see people transform. So cool. And that he can have that kind of support. So that was great. No, really.
It's amazing how just buying someone a few pencils and erasers can change their life. I'm not kidding.
Literally.
Yeah. Very cool. All right. Well, thank you, Brandon.
Thank you, guys.
Stephanie. All right. Phoenix Counseling, John Boehm. Updates.
Hey, good afternoon, everybody. Just want to throw out a couple of quick shout outs real quick. If you guys don't know much about Recovery Cafe, please take the time and check into them. What Brandon, Stephanie, and Christy doing as far as that next step, bonding, connecting, getting people together, it's just absolutely fantastic. So very cool. Also wanted to say shout out to Nathan and the team over at Addiction Recovery Center for allowing some of the Phoenix clinicians to use office space over there. That has been much appreciated. Things are going well, business as usual, and we're just moving along. So thank you.
Very cool, John. And besides seeing lives transformed, seeing agencies reach out and support each other like that is the other thing that really energizes me about this group. So very cool to hear on both fronts. Thank you. Eddie, on track. We'll kick it over to you.
Hey, everybody. Just very briefly, all of our outpatient and residential programs are open, and two of our residential programs, the DADS program and Mountain View Recovery, actually have some spots available. So call our main number if you know of clients who may want to get an assessment and might need some residential treatment, 541-772-1777. Otherwise, just happy to see everybody. Everything is good here, just moving forward.
Awesome. Thank you.
Eddie, what was that? The DADS program, and what else has room right now?
The facility up in Josephine County in Hugo, Mountain View Recovery.
Thank you.
Awesome. All right. And Kristen left me a note prior to having to step out for an urgent matter. She also said the contingency management was fascinating. But she said the update was that, they're excited to have been selected for Project Nurture to support pregnant women with SUD in our community. They look forward to launching updated prenatal OB program in the spring and sharing more with you. We are currently recruiting for a mental health provider with SUD experience. This position is posted on the website. She said she's continually grateful and impressed with this group. Thank you for your incredible work. I know there's probably confidentiality issues at stake, but I would love to see pictures of babies because that always cheers me up too. So we'll put that out there maybe next time. But let's see. Medford Treatment Center. Joanna, do you have some updates?
Yeah, hi guys. So a couple of updates. We just started construction on the second floor of the building that we have to move our matrix program over there. So that's starting to be redone on the inside. And then the contingency management is the other kind of big one that we're gearing up for next month. And that's based off of stimulant-free drug screens. Those that we have identified that have a history of stimulant use. And those are the two biggest updates right now.
Awesome. Thank you. All right. Julia, Max's mission. Oh, I think you might be muted. Do you have a...
Thank you. There we go.
We got you.
So in response to the yellow overdose alert that Jackson County was in up to about a week ago, we brought forward one of our meetings in Alba Park. And subsequent to that, we got covered by KTVL and had a huge response for our naloxone by mail. So that was interesting just to see how many people contacted us. And so continue to do the nalox boxes. We would like to put more up in Medford. So if anybody feels they could have a box at their site, please contact us. We do have more boxes to put up. And I think there's probably a need. We're missing certain towards West Main, out towards East Medford a little bit. So anyway, please let us know. We'd love to put more up.
Awesome. Thank you. That is such inspiring work. Sarah, it says La Clinica, but is it more Birch Grove, the update you would give, or certainly whatever you wish to share?
I don't really have an update this month. I do notice that we're getting more capacity in the ex-waivered providers, but I don't feel like I have much else to add. I did just get a little note from Adam Trotta about the MAT community. So whenever you want that.
No, absolutely. I think we have him update at the community updates right after this. So we will have a spot.
I think he had to leave.
Oh, shoot. Okay. So do you want to give that now? I think it would be fine.
Sure. He just said to let people know that they're beefing up or starting the curbside consult service at Rogue Regional. So that's to help doctors within the hospital prescribing buprenorphine and taking care of people who have opiate use disorder. So they've been working on that since December 1st. He said they get about 2 calls a week for the consult service. We're hoping to ramp up after the DEA rolls out the new X-waiver rule change. They mentioned it a couple weeks ago, but I don't think it's really parsed out yet. And that's it.
Awesome. Thank you. It's a good update. Cynthia, Copia.
I don't have any updates, but I will totally echo what John said. That we just appreciate all the, Reclaiming Lives and Recovery Cafe is doing amazing work. The ARC has been an amazing community partner through, the fires and the COVID challenges. And yeah, so I just got off a call with I had a call this morning with the directors of all the said organizations, and it just is awesome to see everybody come together to serve the community, and it's really a privilege to be a part of that. So that's pretty cool action to watch. I love the on track, counselors are over at ARC facilities. I mean, how much more camaraderie does it get than that? That's pretty amazing.
That is awesome. Thank you. Well put. Dane with HIV Alliance, I feel like you guys have been hopping lately.
We've been doing a lot of stuff. Jordan, who kind of runs our Prime Peer program, she said there were 2 left to hire. We are going to have 3 in Jackson County and 3 in Josephine County. And so we're excited about that. I know one of the people that they hired for Josephine County, and she was our syringe exchange coordinator for Lane County. So she is just awesome. I think she'll do a bang up job down there. A little bit along the lockdown for just Jackson County, we hit 1,154 IM doses for the last half of 2020, 160 nasal doses. That's about 1,314 doses, or 737 total kits. And that was about, we did 86 new clients and then 204 refills. And I think the cool thing is we saved 55 lives, and that's about 26% of the clients that indicated they needed a refill was because they saved a life. So that's awesome. We don't do syringe exchange in Jackson. The county does that, but we do syringe exchange, and kind of give you a little dynamic of what we're seeing in Josephine County. We've seen a lot of growth. Served on average about 143 clients a month during that 6-month period. About 32 of those clients each month indicated, so 33% that they were multiple exchangers. So if you add that, 57 clients that those multiple exchangers on average served, that's about 200 clients a month that we're serving. And I think one of the strong indicators, I have a full female staff down there, and 45% of our clients are female that use our syringe exchange in Josephine County. And I think that's pretty tremendous. And I think it has a lot to do with Harmony and Lisa and the team, that they just, they feel comfortable coming in and that overcoming that barrier. I hope to see that we can get some of those clients. Harmony's really great about, she put her own resource guide for treatment together for Josephine and Jackson County, and she's handing that out quite readily. We ask at every intake on every client, are you wanting to engage? Do you need some resources? And I think when we have all the Prime peers in place after the training period, that's going to be great, having them as part of our syringe exchange too, and being there where they can kind of like lead those clients to treatment. We only do K-Junction on Mondays. We're switching that to Tuesdays in February to overcome the holiday barrier of closing on Mondays. And then we do Grants Pass every Thursday. And in Southern Douglas, which I kind of consider Josephine County, we just started Glendale every Friday. We're going to be doing syringe exchange. So it's really cool to hit another small community. What pinpointed that area is where we've been working with All Care. Sorry, we also know that we serve a lot of clients coming from Glendale and Wolf Creek coming into Grants Pass. And a lot of those are the multiple exchangers. So they're exchanging for multiple people. We're hoping to better serve those by decreasing the transportation barrier. So it's just great to be able to serve as another small community and help more people protect themselves, and hopefully we can engage them in treatment. You know, Heart of Harmony, she put all the providers that are doing online treatment, like Boulder Care as an example. You know, OHSU has one. So we put those in our flyer also so that we can connect people to care. But we appreciate everybody's buy-in down there for helping us. And so that's pretty much our update.
No, that's excellent. And I'm glad the folks in Glendale and Riddle and maybe even Myrtle Creek are getting help, but I won't tell them you said they're really part of Joe County. I know that's those Southern Douglas folks, they're going to want their identity, but it's great that they have access to services. So thanks, Dane. Let's see. Next on our list, Boulder Care, Justin.
Hey, everybody. No major updates right now. We are still restricted to just Blue Cross Blue Shield Regents or Primera, both. And we are working diligently with Care Oregon to open that back up, and it will be happening. It's just a matter of when. So we're excited that will be, soon, and we'll be able to have more access. And I'm really excited because as soon as I'm done speaking, I'm going to hang up, and then I'm going to go do an intake at the JCCJ with one of our care advocates. So good seeing everybody, and I'm gonna go away.
But when you say JCCJ, you're talking about the transition center, right? Which,
yeah.
I think that's pretty exciting that these people who are in a facility where they're serving out a sanction have access to this kind of treatment and care. And we've always looked at it as a time for them to stabilize, but the idea that they could actually engage in care before they're out, getting supports from the ARC as well. It's exciting to me. So very grateful for that, Justin. Thank you.
Yeah, I think one thing that's really, really cool is that, they, even if they just use us just for right then and there, they have someone saying to them, we support you, meaning that if they disconnect, they have a place actually they can go back to. And we know that the people that are in need, the more resources, the better. Right. So we're just excited just to be one part of that connection. So it's pretty awesome stuff.
Awesome. Well, thank you very much.
Thanks all. See ya.
Jody from Allied was here earlier. Are you still with us, Jody?
I am. Thank you.
Awesome. Yeah.
We're staying busy. We're fully staffed. We have a pretty new team there, which is just doing amazing. And we're finishing up on our remodeling and just staying busy. We've got a lot of group attendance and one-on-one sessions, so it's going really good.
Great. Always appreciate the updates and the work you're doing. So thank you. And Nathan with the ARC.
Thanks, Eric. So as Justin mentioned, we have MATCH restarted from the jail, and it's now at the transition center. MATCH stands for Medication Assisted Treatment and Confined Healing. So we have a CRM that's meeting with the clients out there remotely who are engaging in MAT services. Really great opportunity for the clients and for the community. We also have offered COVID vaccines to all of our residential staff and clients at this point. And we've begun offering it to our outpatient staff as well. So with hopes of making a transition plan back to campus at some point. And I think that's about it. We're still recruiting for more certified recovery mentors and CADCs as well. So that recruitment process is actively going on.
Cool. Thanks, Nathan. Appreciate it. Moving on to Cco updates. I know Jeffrey had to step out early, but Darren, are you with us? Looks like you're there for an update from Jackson Care Connect. Oh, I think we got you on mute there. Did we do that?
This is Julia. I can jump
Julia.
if Darren
Jackson. Oh, there he is. Go ahead, Darren, take it away.
Okay. So we were just saying how we were just a great meeting. It's nice to hear John Mann talk about the contingency management program and give a nod to JCC. I think we supported some of that work with La Clinica with a similar program, but it's just really nice to hear because most of that clients that he's talking about are JCC members. So thank you, JCMH, for providing such good care for membership. So I just wanted to kind of lead with that, along with all the other providers here that are providing good care for our membership. So we have, things are busy at JCC. We're really happy that I just learned that we have renewed our contract with Neil Clean Syringe Exchange Program. So that's great. That's just hot off the presses. Really happy to continue that work. Still working on building MAT capacity. Are in the middle of a learning collaborative focused on team-based care. That many of the folks or agencies represented on this call are participating in. That's across. It's kind of an effort with our other CCO partner up in the North Coast, Columbia Pacific CCO. Another big update, I think, is we've now been landed on a contract with Dual Diagnosis Anonymous, who is in partnership with, I believe, Compass House is providing groups through the Compass House. So DDA is back in our system of care. Looking at the list here, we made we have a hire announcement. We hired a traditional health worker liaison, which is which many of you might know, Cliff Juno. He was previously with JCC, but his role is going to be really building capacity for traditional health workers and peers and doulas, which are kind of under the same umbrella. But specifically for this group, he's going to be helping. First, going to do a community assessment or within our network about what the capacity is there, but hopefully will help us from the CCO lens in building capacity for certified recovery mentors and just looking forward. That's a brand new position, so looking forward to that. Julia, did I miss anything? I think that's about it.
Got it. Thanks, Darren.
All right. Well, thank you both very much. Let's see. We also have the Oregon Pain Guidance Naloxone work group. Sarah, do you have any updates on that?
I'll just pass this month.
Fair enough. And then for the good of the order, anybody else have updates that affect SUD in Jackson County? Once again, I really appreciate this group. Commissioner Dyer, it's great having you back. Look forward to continuing this work, and your commitment to it has been really welcome, and we're grateful for that. And for everybody else, if you do have folks or topics that you'd like to see us tackle, please send it to Sarah Smith or myself, and we'd be happy to see what we can arrange in the future. But today was outstanding with Dr. Mann, and we'll see everybody next month. Thanks.